สวัสดีค่ะทุกคนนะคะ Okay, so today's my topic is gonna be about enhancing your potential with self-ligating bracket system. And I have so many questions asked me during these years of my practice, like, why do you prefer self-ligating? Can you not go with conventional? One thing that I'm very grateful is, before we go over all this, is thank you so much for Ormco for inviting me today, and also Dr. Krish Hine, Dr. Travis Nichols, and other doctors that's joining me on this stage. Very privileged for that. Okay, so let's go into the topic here. I want to introduce myself a little bit. I graduated from Chulalongkorn University for my bachelor degrees, and then I pursued my master in St. Louis University. After that, I got a diploma at American Board of Orthodontics, and then I also want to learn more. So I do cleft and lip and palate fellowship at Children's Hospital in St. Louis. And after that, our great Dr. Moshiri has produced his own course on aligner. And with that course, I took a 6-month long in online courses, doing that in Thailand and get the aligner intensive fellowship. If any of you interested in doing learning more about aligners, I think this is a great course that you could start with. So my area of interest involving self-ligating appliances, doing the clear aligner, doing some early treatment in kids, which is I like a lot, and also the TADs, which is the temporary anchorage devices. Our 30 minutes presentation today is gonna go over the pros and cons of using self-ligating bracket system. And then I'm gonna go over one extraction case here. I don't have much time, so I wanna produce the knowledge that you can all bring back and apply to your practice. It could be one thing, it could be two things, and that's enough for me. If you go back and you improve your practice with something you gained today, then that's great. And then I'm gonna go over some bonus track on tips and tricks. All right, so we have these brackets here. You have the conventional, which are the metal. There's the ceramic one, and then you have the self-ligating one. So what are the differences? Let's see some hands here. Who of you guys are using more conventional brackets than self-ligating here? I just wonder about that. Do we have more hands? Okay, so I would assume that the rest of you use self-ligating now. Is that right? No? Okay. So in my experience, when I ask away, I think most people are using conventional brackets more than the self-ligating. And that's something we could go over, why are you doing those? Can you change to a new, more modern self-ligating brackets? Would that be beneficial, or would that be just the same? So we're gonna find that out together today. So before I go to my own point of view, I want to go through some evidence here. And this is one of the evidence that has the strongest, highest level of the evidence. We are doing a systematic review of self-ligating brackets. And after they put all the researchers together, they found out only 2 facts. One is you have less chair time. You can close the door, open the door, you don't have to put O-rings on, take it off, and sometimes you don't even have to change it, right? If you want to stay with the same wire, then just keep the same wire. Take a look and then let the patient know, come back later. The other thing that we found different is the mandibular incisor proclination. So we found that we can control it a little better, about 1.5 degrees. So that's what the evidence shows. Now, I'm gonna go over some other AJODO articles. These are the lower level of evidence, but still we can learn something from it. So the first one is talking about the treatment efficiency from conventional and self-ligating brackets. And they found that you could get a quicker, more efficient wire removal and placement to most stages in orthodontics. There's another research shows talk about force decay and deformation of the O-rings. And with this one, like they found that if you have elastomeric ligatures and you have plaque accumulation around that areas, you also find sometimes the wire doesn't seat it all the way, especially with torquing and rotations. And then you could get some biting during the sliding mechanics. We didn't talk about force decay rates and how the O-rings change over time. So those are the things that we found for patients with O-rings. Then another research talk about comparison of efficacy between self-ligating and conventional braces. And with these, like we found that in the first 22 weeks, self-ligating doesn't show any more efficiency than the conventional brackets. So ligation techniques is actually only one of many factors that can influence the efficiency of the treatment. Okay, hold on. Okay. All right, so from here, like, if we look at all these articles, like, doesn't seem like there are much difference, right? And then why do we use self-ligating brackets then? Why do we come up with so many inventions? Why do we pursue like new technologies each year? Because there's actually something fruitful from it. And what I'm gonna talk about now is from my experience. And you can see like these together. So the first thing is there is no elastomeric ligatures. So if you think about it, like if you wanna do ceramic brackets, would you do the clear or ties? Maybe. And you want it to be clear, right? But whenever you put these in, like whether it's gonna be like GAC, it's gonna be Ormco, it's gonna be AO, it's all gonna stain, right? Eventually. So if you don't have O-rings, then you don't have stain, and you don't have the change of color ties. Then you also don't have any loss of the O-ring itself. Sometimes patients go for a month, come back with no O-rings anymore, and then the tooth escape from the wire. And also you have no problems of force decay of the O-ring itself between appointments. So one thing that I found very beneficial is during COVID, you cannot see patient every month, right? So what happened is you might be a little panic now, like you are back home, like, is the O-ring loose or not? If it's coming off, like what the patient's gonna look like after 6 months. But then if you have self-ligating brackets, it's hold the wire there. It doesn't move, it doesn't decay. So I kind of sure that whenever I see my patient back, they're gonna look better because you let the wire cook for that time. And if you are closing the space like keeping closed. Next thing is the secure ligation. And this is the one thing that I think is very, very good for self-ligating brackets. You have a very tight door and it's secure, it won't go anywhere. So you have the precision. If you want that precision in conventional brackets, you have to put steel tie there, right? You have to tie it very tight so it won't escape. Like otherwise, like once the old ties are faded out, like eventually like the wire is gonna move again. So with this precision, like you get very little to no canine rotation during space closure. You got very little to no rotation during the space opening. And then you don't have to steel tie so much, so you reduce the share time. And you have less appointments with more appointment intervals. So what's good about that? Time is money now, right? Time is what very valuable for all of us. So you don't have to see patient as often, which means like you don't have to spend a lot of share time there. And your patients as well don't have to take away time to see you as often. And let's say like if you wanna treat patient for 2 years, with conventional you might have to do 24 visits. But with self-ligating you might do 12, 10, or maybe 4. Now less plaque. So about less plaque, like I think this one we can argue on. So you know, like whenever you have Damon brackets, we will talk about, oh, it's faster, it's less pain, it's cleaner, things like that. So plaque, I think we can all agree that there's less plaque around the brackets. But then, is this really less plaque? That's depend on how patient brush their teeth, right? How they clean their teeth. Like the plaque could be on the gingival margins, it could be interproximally, so that depends. Okay, next thing is the strong door. So this one I enjoy a lot. So I have to say that I got the privilege of studying in St. Louis University, which is like one of the biggest residency in the world. We have 14 residents in each year, and we got 3 years of residency. We also have 40 faculties, so we get to use every single brand in the world. Like we get to use CSC, we got to use for resident, we used to do like Carrier, use Ormco, things like that. So I can do the comparison of our doors and our self-ligating brackets, and I find out that the Ormco actually has the best door. I got to admit to that. So it's like driving a Ferrari, like you have this rigid strong door that you can rely on and it doesn't really break at all. It also have an easy way to open, like spinning the opener. Like if you use other brands, like you have to pull it up and down. And what happens is sometimes you pull it too much and then the door breaks. And when you put it back on, it doesn't lock anymore. So whenever that happens, you have to change the brackets and that's create more chair time. Now what about comfort? So is it less pain? So we gotta talk about where the pain comes from, right? So it could be wire poking, it could be a big tube poking you in the cheek, it could be discomfort from teeth moving. So is it actually less pain in that case? I would say it's very subjective. Like one patient could say, oh, I don't feel anything at all, and then you have another baby crying patient, right, that say you hurt from day 1 until day 10. So I think this is very subjective, but then we do be able to prove that like they have smaller tie wings since they don't have to put O-rings on. And then they have rounded corners which offer some comfort there. They also have this added hook, which I like a lot. It's reduced the discomfort from using unnecessary hooks. Like if you don't need hooks there, then you can add it later. It's also very solid compared to K-hook. So I think a lot of you guys have experience on doing K-hooks already, and sometimes it breaks, sometimes it moves, and sometimes it's poke the gum. Next thing is the torque selection. So this one, like with Damon brackets, you could do torque selection from low, standard, and high torque. And what is the better way to gain aesthetics? That's controlling the torque, right? If you can control the upper incisor torque well, even you have some protrusion there, it still looks nice. So in order to get to that place, like if you get some help from the bracket itself, then that's awesome. Next thing is the arch wire, and this is about Damon mechanics now. So with the arch wire, if you compare Damon arch wire to other arch wire, they are larger than normal actually. And because of that, we need less RPE now, right? I still use RPE in my practice, Dr. Chris. I found it's effective when you want to break the sutures and you want to get some skeletal expansion. Then I also gain more dental expansion from using the Damon arch wire itself. So this is help facilitate arch wire expansion in non-extraction cases, and also reduce the need for extraction in borderline cases. They have very convenient arch wire size, so you could go at 14, 18, 18, 25, things like that. All right, now let's talk about the cons. So there are complaints, right, on doing Damon brackets, like, oh, I don't like it because of this and that. And these are the things that I could gather together. Like they have small tie wings, so if you want to put all ties there, patients want colors, right? It's quite difficult. And then if you want to do double chain, that's also very difficult, or if you want to do under ties, things like that. So you got to use Q2. Those are the problems with the Q, and then once they have Q2, like they improved that part already, but I have to admit, like it's still more difficult than the conventional one. The rigid door. So what it's about rigid door? Because the Damon has strongest door, it's also very rigid. Like if you use some other type of self-ligating, it could be a little like an active clip. So when you close the doors, actually give you some room of error. But with Damon brackets, like you have to be fully level and aligned. So if you're not fully level and aligned, when you close the door, it's gonna break. And the way to solve that is you wanna put maybe a little larger copper nitrile wire. That way, like it's got a line more than usual, and then you go with 25 stainless steel arch wire later. That would be much easier. Then for the debond, like they have more debond rates for me because they have larger brackets with their self-ligating door. So your bonding technique has to be very good if you want to use these brackets. Finishing difficulties is something that we talk about all the time, and that's because the Damon bracket is larger than normal. And with that, like you got some plays there, you got rotational plays, you got torque plays. So how to deal with that? Like you could get to 1925 maybe, and that would engage the slot almost full. And then you get less rotation. You could do also bracket positioning. So why not do some compensation? With that, like it actually helps improve your finishings, like with good bonding. There's less work in reposition and finishing later. Lasting last is not always a non-extraction case, and I want to stretch on this because whenever you go to Damon forum, which I like, very helpful in a lot of ways, we will talk about doing non-extraction cases here and there. But if it's an extraction case, it has to be extraction case, right? You do the diagnosis already. So the treatment plan should be based on the diagnosis. All right. I only have 10 minutes left now, so we're gonna go over other things pretty quick. This is one case that I wanna bring up and see like how I utilize the Damon brackets in my practice. She has a lot of crowding in the anterior and posteriors, and you can see that there's no room for the lower segments to come in anymore. So the plan is we're gonna do the step tracing here. There's not much deformities in skeletal, but you can see pocli, upper and lower incisors, and full lip. Okay, so that's the diagnosis. Like we got class 2 myoskeletal relationship with a very large overjet, a lot of severe crowding, labial version of upper and lower incisor inclination, acute interincisal angle, and protrusion in the upper lip. The plan for this case to do 4-by extraction and also take out lower 8s and do some surgical exposure on those teeth so you can put their brackets on. Then I do the normal sequences. This is my treatment sequence. And I do it a little different on each cases, depend on the need for those cases. I want to emphasize that I no longer do extraction case for 24 months anymore. Usually it take about 18 months. With good planning, you could get a good outcome in a good timing. So you could do 14 nitile and 18 nitile at first, and then I just keep leveling up. I go to 1425 copper nitile arch wire, and then the 1925 arch wire that I'm talking about. So that's my transitioning arch wire. And after that, I go back to 1825 stainless steel arch wire to close the spaces. With this, I combine that with the memory chain. So the memory chain actually lasts longer than the normal chain. And if you do that with the self-ligating system, you got 2 powerful mechanics that works well together. If you want to go even longer than that, you could use the closed coil spring. And then you can just wait, right? Maybe 4 months, 5 months. After I close the space for 7 months, then I start to do my finishing for another 5 months. And then that's it. So this is the progress that you can see, like from the first month here, you can start seeing the canines are moving very quickly. If you do it right away after extraction, that's when the teeth moving quick. Then that's 3 months. You start to see them all in a line. And that's 7 months. So after 7 months, like everything is in good alignment now, and I start close space at this point with class 2 supports. Then after a year, all space is closed already. And then this is the time that you can actually finish if you want. But then I like to do my finishing about 4 to 5 months. I like to take time working on the details like torque, the bends. And also like to keep all the space closed for a longer while. That way whenever you debond, you get a good stability. So that's when we finish the case. So overall time is about 1 year, 6 months. Now let's see what the cephalometric says. This is a panoramic X-ray showing good root paralleling. And then this is the post-cephalometric tracing. So we compare that, you can see that there's not much change in skeletal. It's pretty much the same up here. But then you see more change in the dental here. So the upper and lower incisor retrocline more, retracted more, and then you get better lip support. So this is a pretty straightforward case. You do full bisection, but the things I want to emphasize is you use up 18 months with about 14 visits, and that's already better than 24. This is the final record of her case. And that's what we all aim for, right? To creating good straight teeth and a happy smile. Alrighty. So the last 5 minutes that I want to talk about is about other tips and tricks. You could use brackets for other purpose, and this is one thing that I find out on my own. So with the impacted segments that we see more nowadays, it's very difficult to bring those in without having a good torque. So think about it whenever you bring in impacted upper segments or lower segments, you put the brackets on the buccal, right? So you would pull in the buccal cuts first. And then what about the lingual? It doesn't really come up that well. So what I did is I put a very rigid arch wire on the buccal, and then I bond the lingual cuts. And with that arch wire, it can bring in lingual cuts into the same level in the occlusion. We got a very good result in the lower as well. So in this case, the same is the impacted 4-7. And why I'm bringing that in, the tooth tilt, and the lingual cut is so close to the gingival margin that it doesn't get into occlusion at all. So we apply the same techniques there, put the lingual brackets on, and voila. I also use other different techniques, I think I still a student for life. And because of that, I wanna try different techniques and see how it goes. And this technique is very popular in America because we are trying to avoid putting tats near the tooth. And palatal is actually the safest area that you can do. So if you put palatal tats there, control the anchorage in the back, then you can get a maximum anchorage while pulling and retracting the upper incisors. With this case, so in my experience, patients like to avoid using tats. And that's what I do for the past 5 years. I try to avoid using tats as much as possible. So in this case, it looks simple, right? But it's actually very tricky. So with this case, you have to take out the AB canine there, and then you move all those 3 crooked teeth into the straight alignment. But then you have to keep the same midline and the class 1 occlusion on both sides. So how are you going to do that? That's a maximum anchorage case. So it might be easier to use TAD and then pull everything into place. But then because patients is asking me like, can I do it without TAD? So we are using TPA instead. And with the TPA, you get the anchorage from the other side as well. So you're doing something on the left, and then you get anchorage from the right side. And with times taken there, we could get a nice, beautiful alignment at the end. Another thing that I want to pass on, this is one of my own techniques that I use regularly as well. So if you read about articles on surgical uprighting, it's actually 99% success. And you don't have to use braces for that long to upright the tooth. So if you go from this picture here, Okay, if you look at the lower 7s here, you can see that they are tipping, right? And then if you look at another panoramic there, it's uprighted right away. So that's happened in 1 hour. And how you do that is you can use the surgical techniques like taking out the aids and then use the elevator to upright it. There are some indications that you have to be careful on, but if you look at the right criteria, then you can upright the tooth just like that. And then after that, you put on brackets later and then level and align, so you don't have to go through so much troubles in these cases. Damon Q can also be used with the ICC screw, and that is one of my favorite screw right now. I use it for upper arch visualization quite a lot, and it's very helpful in cases where the patient is non-compliant. All right, so to conclude this seminar, I wanna talk about the tools. So because we're here with talking about Damon brackets, I believe that you all can get a good outcome. But it always begins with the doctor and the right tool to help transport you to get the expected treatment outcome there. It's whether you want to go by bus, whether you want to go by train, or if you want to go fly there. So you could go for conventional, you could go self-ligating, and you could go clear aligners. So let's look at this. What techniques do I use? This is the class 1 patient. What about this case? This is the class 3 patient. And then you have another class 3 with very crowded teeth. And then you've got another class 3 here, which is the surgical case. This is actually very challenging for me, and I got it finished beautifully because she's my friend. We have a same understanding, and the patient's very compliant. What about this case? And then what about that case? Can you tell? You cannot, right? Because you can get there by any tools, but how you get there is the important part. And at the end here, I wanna bring up the speech by Dr. Peter Wick, who said that we should consider that ourselves as a craniofacial biologist. Too many orthodontists have a mechanistic views of orthodontics. So in this regard, self-ligating bracket system is only one of a tool that we use today. Therefore, it is just a component of orthodontics. Among other things, orthodontics deal with science, evidence, psychosocial issue, record taking, diagnosis, treatment outcomes, art history, enhancements, and quality of life issues. So in the future, we certainly know that there are going to be more changes, there are going to be new things, new technologies coming out. Therefore, we should be adaptable and prepare for the knowledge to be undone, rework, and revise. Because nowadays we have Bruce coming, we have Light Force coming, we have Graphies coming, and then we have Spark coming. So we should all be prepared for that. And these are the beautiful smiles I have created. I'm very grateful for all the knowledge that I gained throughout the years. And I hope you guys have gained something back today as well. Thank you for this invitation and a very warm support that you have gave me. Wish you all a good life and a great trip and outcome. And I believe true acts of goodwill always sparks another. So if you have any other questions after this seminar, you have these contact info here that you could contact me. I'd be happy to answer every questions. Thank you very much.
ขอเสียงปรบมือดังนะคะให้กับทันตแพทย์หญิงบุษดีแสงเกลรำวัฒนาค่ะที่ได้ให้เกียรติมาพูดในหัวข้อ Enhancing Your Potential with Self-ligating Blanket System ค่ะและในช่วงเวลาถัดไปนะคะเราจะเข้าสู่ช่วงเวลาของการร่วมเฉลิมฉลอง Ormco Celebration พร้อมกันอย่างเป็นทางการค่ะและในลำดับนี้นะคะดิฉันค่ะขออนุญาตเรียนเชิญ